So next Thursday you will be, Ketan, you will be getting this, no? Box full of this thing
Yes, ma'am.
vaccine.
You can start now.
Dr. Ketan, sir, will you be getting those vaccines
Yeah.
next Thursday?
Yeah.
Yeah. Should I start, Dr. Ketan? Good morning and welcome to today's webinar on allergic rhinitis and obstructive airway disease. This is specially organized by our president, Professor Dr. Ketan Mehta. We all doctors have treated more than 100 patients of allergic rhinitis in our family practice. Isn't that so? But the common question asked is, why me? Is there an answer for an allergy? Can we find allergen? And if so, is there any new line of treatment? And many more such queries will be explained and updated in today's KEP webinar. Friends, area allergic rhinitis and its impact on asthma, the guidelines, all this will be explained to us in today's webinar. Now I hand over the proceedings to Mr. Amulya Pednekar. Thank you.
Thank you, ma'am. I'll just be sharing my screen.
Hello. 1 minute. I just wanted to say something else.
Yes.
Every Thursday, friends, every Thursday, we will be having a vaccination camp at IMA Hall, Juhu from 2 to 4 o'clock in the evening. There will be lunch at 1:30 followed by CME and also the vaccination camp. The vaccine is flu vaccine tetravalent. This is absolutely free for all the members of IMA Mumbai West only. We have limited quantity of this vaccine, so please try to be very regular and with this, the Thursdays will be only covered in this month. So we have now 3 more Thursdays. So please try to come on in time and avail this opportunity. This has been organized along with Dr. Ketan Mehta and Malad Medical Association. Please register with the staff in IMA Mumbai West. Give your name, bring your Aadhaar card. You will have to fill in a form and give a Xerox copy of Aadhaar card. So do not just get the Aadhaar card, but get a Xerox copy of it, which you will have to pin to the form and hand it over to us. This we will start from next Thursday. Please avail this opportunity. Thanks to Dr. Ketan Mehta, who has organized this camp. Thank you, Dr. Ketan, sir. Now I hand it over to Mr. Amulya.
Okay. Thank you, ma'am. Thank you so much. I hope my screen is visible. So I'm Dr. Amulya Pednekar. I'm medical advisor for Zydus Life Sciences. And on behalf of our whole Zydus team, I welcome each one of you for this today's webinar on crosstalk on obstructive airway disease and allergic rhinitis. We have doctors coming all across India. There are almost 1,800 odd doctors that have joined in. As you all know, Zydus has been in healthcare sector for last 70 years. And we have only one motto, that is dedication to life. Zydus is continuously involved in research and innovation. And as a testament to that, Zydus is the only pharma company in India, the Indian pharma company that has a new molecular entity, saroglitazar. We are also the first company in the world to have the biosimilar of adalimumab. We at Zydus always believe in education, and as a part of that, we are here today to attend this webinar and understand more about obstructive airway disease and allergic rhinitis. I would like to thank IMA Mumbai West for giving us this platform for this educational talk today. This wouldn't have been possible without Dr. Ketan Mehta. I don't think he needs any introduction. He's a renowned consultant physician known across India. He's the president of IMA Mumbai West. He has been the Honorable General Secretary of Indian Society of Electrocardiology. He has been Organizing Secretary at ICON 2022. In the past, he has been associated as Joint Secretary with the Indian College of Physicians and National Society for Prevention of Heart Disease and Rehabilitation. He is the Trust Board member of MMA. He is the Organizing Secretary. He was the Organizing Secretary at Diamond Epicon 2005. He's the President of AAME. He has been he's been on the editorial board of multiple journals. Few of those are JP and Journal of Medical Nutraceuticals. He's been the PG teacher for FCPS, and he's been the ex-teaching faculty at KJ Somaya Medical College. He has also been involved in various clinical trials as a principal investigator. Few notable amongst those are TIPS 3, HOPE 3, TIPS, and multiple other clinical trials. Our second guest speaker today will be Dr. Suryakant. Again, requires no introduction. He is the National Vice Chairman of IMA AMS. He's been president in the past of Indian Chest Society, Indian College of Allergy, Asthma and Applied Immunology, Medical Science section of Indian Science Congress. He has been the governing body member of AIMS Patna. He has been the chairman of North Zone Task Force for TB Elimination. He has been the member, National Core Committee, Doctors for Clean Air. He has been the convener of TB, Tobacco and Pollution Free Campaign. He has multiple publications, multiple books that he has written and co-authored. He has around 19 fellowships. He has 2 US patents, and he has also has a lot of community participations via multitude of NGOs. So I thank you. I say thank you to Dr. Suryakant for being a part of this panel today. Our last speaker today will be Dr. Parthiv Mehta. He is a renowned senior pulmonologist who is practicing in Ahmedabad. He is the mentor for COVID critical care for Government of Gujarat. He has been the honorable pulmonologist to Governor of Gujarat. He has been the medical director at Mission Life India, and he has specific interest in academic public awareness training and research. And he is here today to give a talk for us. And I thank you, Dr. I say thank you to Dr. Parthiv Mehta for giving us his time. And without any further ado, I think I will hand over the platform to Dr. Ketan for his. He'll be the moderator today, and I'll hand over the platform to him to continue the talk further.
Thank you, Dr. Amulya, for those kind words and introduction. Friends, as Dr. Shobha Madam has already told you, today's program, which is again different in the way, now when we have moved again back to physical CMEs. And why webinar? Because webinar would have made it possible to have you the best of Indian faculties from different part of the countries, my dear friends, Dr. Parthiv and Dr. Suryakant. Otherwise, you think with their such a busy schedule, they would have spare time and come to Mumbai, India, Mumbai West, which is so difficult to get them. In fact, I am booking them for 2023 right now. So 22 to it becomes absolutely out of possible. So that is the reason we thought, yes, webinar. Now, today's webinar, which has been titled as Crosstalk between allergic rhinitis and obstructive airway disease. Now, what is this crosstalk is? There is definitely some connection, and there is a cross connection, what we talk about when we talk about allergic rhinitis and when we talk about the obstructive airway disease. There is also a connection with this same subject between a pulmonologist and a physician internist. And at the same time, there is also so much cross connection. I'm sure Parthiv would agree. And there are so many times which we fight about. In fact, our another close friend, Dr. Agambura, where we share in the same hospital patients, and we just say, he said, no, this is doesn't come in my territory, or it is not, the issue is not related to my problem. It could be your cardiology related, and we feel similarly, no, this is not cardiology related issue, it could be you. So there is so much cross connection on it. And that is how we decided we will have this crosstalk on these common subjects. And that would be again between a pulmonologist and internist, so that we can clear out so many issues on it. Friends, to let you know that this today's program has been given one MMC credit point, and we have Dr. Smita Lele, who has been there with us as a observer from Maharashtra Medical Council, who has joined with us. So with this, I would like to start my first presentation, which is I would be talking on the subject of COPD and CVD comorbidities. Is my slide visible?
Yes, yes, it's
Okay,
visible.
fine.
Yes.
So
Yes,
I
it's
would, okay, so I would be talking on this subject, COPD and CVD comorbidities and case-based approach and management. And friends, I'm sure when we talk about it, it is so difficult to see whether it is in my practice, Parthiv's practice, or even you as a family physician having a single entity. It doesn't come as this thing, it comes as a package. And what is the bottom line is we need to take into consideration all those aspects and treat the patient. That is what is most important. So I would be covering the certain introduction. I would start with the case, then talking about the pathophysiological links between COPD and cardiovascular disease. Then need to talk about the management of both conditions per se together, that is talking about COPD and cardiovascular disease. And finally, the concluding remarks on that. So talking about the initial part about it, when we say COPD or chronic obstructive pulmonary disease is nothing but it is a complex respiratory disorder characterized by chronic airflow limitation and increased inflammatory response of the lung. We all know and we all have been seeing this entity. Of course, today it's not possible to discuss the differentiating point between bronchial asthma and COPD, but I'm sure all of you know that. What is interesting to know is that 4 out of 5 COPD patients have at least one comorbidity. Now, that is a huge numbers we are looking at it. So that means only 20% of COPD patients are having only isolated COPD. And the reason for is that the cardiovascular disease and the COPD has got the similar risk factors. Of course, the age is the commonest factor. Besides that, smoking, other exposures, sedentary lifestyle, and all these frequently coexist, and as a result of which we have COPD and cardiovascular disease which are existing simultaneously. Now, what is the problem when they are existing together? The problem is once both these conditions exist, there is the higher rate of morbidity and mortality. So there is definitely a poor quality of life. Person will feel breathless even on slightest exertion also. Now, which could have been contributed from respiratory element or cardiovascular element, could be anything. Higher risk of hospitalization. So, if the person is only single entity vis-a-vis a combination, so obviously rate of hospitalization is also higher. And plus the heart failure, ischemic heart disease, diabetes, atrial fibrillation, all these condition also increases the risk of frequent exacerbations of COPD and subsequent mortalities. So they can perpetuate, they can set the fire, and that can cause the problem. In addition, we know that COPD patients come off and on to us and they come with acute exacerbation. But over a period of time, with each exacerbation, we know there is a decrease in the lung function, and which is also going to cause increased CV risk and mortality, which is there. Now, to minimize this risk of poor outcomes, it is very important that all patients of comorbidity with COPD and cardiovascular disease are managed and targeted simultaneously so that it can have a beneficial effect and can reduce the adverse effect because of the concomitant cardiovascular disease and vice versa. Now, just to give you an idea about the hazard ratio of COPD with concomitant various cardiac conditions, and if you look at this, whether we talk of heart failure, atrial fibrillation, flutter, ischemic heart disease, pulmonary hypertension, diabetes, it is huge. So you can understand that the impact is minimal. I mean, is quite significant. And if you really want to see the number game, now, which will be really shocking, that prevalence of ischemic heart disease in a patients of with COPD is 20 to 60%. Prevalence of heart failure in patients with COPD is 10 to 30%. Prevalence of arrhythmia in patients with COPD is 10 to 15%. Prevalence of stroke in patients with COPD is to the almost 10%. Risk of MI in patients having COPD is 2 times compared to the patients without COPD, with all other risk factors remaining same. And the percentage of COPD dying due to cardiac disease is 12 to 60%. It's a huge number. So imagine even a COPD patient may not even die of acute respiratory failure, but can have a higher chances of dying because of cardiac disease. And that is why it is very imperative to understand and manage both these conditions simultaneously. So let's look at a case, and I'm sure which all of us are seeing in day-to-day practice, whether it is a family physician practice, whether it is a consultant physician practice, or whether it's a pulmonologist practice. Here I'm talking about a 68-year-old male who has been a smoker all throughout his lifetime. He is a diagnosed case of ischemic heart disease. He had unstable angina in the past and has been managed medically, is not willing to undergo coronary angiography. He is also a known case of hypertension. Echo-wise, he has got a good LV function and he was doing reasonably well. Unfortunately, now why I am saying unfortunately, because that is what always happens, which we quite often see in our practice. In spite of repeated instructions to him, he continued to smoke. you know we see some patients after being diagnosed ischemic heart disease, and when we tell them to quit smoking, it acts as a jatka. So quite a few also quit, but still majority of them continues to smoke. Now, he had a history of breathlessness for 15 days, and he comes to you as a family physician or can goes to any other family physicians. And what you found is hemodynamically, of course, there will be some tachycardia, blood pressure is controlled. On respiratory system examination, there is a bilateral expiratory wheeze which is there. And of course, being a good clinician, you would diagnose, okay, that now he is developing obstructive airway disease, and because there is a history of smoking. So what he did was he started him on in his clinic itself salbutamol nebulization. First of all, whatever may be the understanding of the concept and all, and gave him salbutamol nebulization in the clinic. And then he asked him that, can you continue this at your residence? And since the patient was having this nebulization machine for some other family members, he said, yeah, I can do it at home. So he was asked to continue as and when he feels breathlessness. And this gentleman continued to take 6 to 8 times in a day salbutamol nebulization. Of course, he was feeling a temporary relief also with that. So he continued at home besides his regular medication for ischemic heart disease and hypertension. Now, few days later, he developed palpitation and he thought, yes, there is something wrong which is happening. And he was not comfortable. So he presented to emergency room. And in emergency room, obviously his vitals were checked. So his heart rate was 160, which was irregular. His blood pressure was normal. His wheezing, of course, was well under control at that point of time. And the ECG, which was taken over here, which is this. So let me just interpret for the benefit of all our delegates over there. So there is, of course, a component of, if you see, there is a, you will see the tachyarrhythmia, which I'm sure would be the first thing which you'll observe. But if you see, there is a atrial fibrillation over here. There is no subtle p waves which is seen anywhere. So this is, and there is a rr interval is varying, so irregular rr intervals with absence of p waves. So this is atrial fibrillation. Of course, he also has left ventricular hypertrophy with strain. We are not going to discuss that. He had already had the poor progression of r in precordial leads. That is all besides the thing. But what is interesting to know is his symptoms was attributed because of his atrial fibrillation and fast ventricular rate, and this is quite often which is happening. Now that reminds me a beautiful quote from Sir William Osler, who is considered as the father of modern medicine. And he states that one of the first duties of the physician is to educate the masses not to take medicine. And you start wondering, why is he saying so? He is the father of modern medicine and he says that should discourage people to take medicine. Of course, he meant is whenever it is really not needed, not to give, only to be given when it is really needed. And then he gives the explanation to it, that the person who takes medicine must recover twice, once from the disease and once from the medicine, which is so much true when we talk about any segment of pharmaceutical patch, whether we talk of anti-diabetic medication, whether we talk of cardiac medication, or whether we talk of any respiratory condition related medications. So each and every drug has two sides, like a two sides of a coin, has got an effect as well as side effect, and that is so beautifully portrayed over here. Okay, so now let's look at the pathophysiological links between COPD and cardiovascular disease. Of course, I am sure by this time you have understood the gentleman had developed atrial fibrillation because there was a underlying ischemic heart disease. There was an element of left ventricular hypertrophy which was seen on the ECG, which was there. I'm sure there would be a left atrial enlargement also. On and above, repeated overdosing of salbutamol inhalation, though it is inhalation techniques which has been supposed to have a negligible or less systemic absorption, but it is still been known. And what this gentleman developed because of his underlying comorbidity, he developed, probably he would have not developed had there not been underlying ischemic heart disease. We don't know. So let's look at these links between COPD and cardiovascular disease also. Now, there are various processes or various phenomena which contributes to this link between COPD and cardiovascular disease risk or cardiovascular diseases. So, with each episodes of exacerbation of COPD, there is additional hyperinflation, hypoxemia, systemic inflammation, arterial stiffness worsens, person will develop exercise intolerance, deconditioning, again, less of mobilization, and all this will give rise to increased risk of cardiovascular disease. And with underlying CV risk or CV disease, again, exercise intolerance, breathlessness, systemic inflammation, which will add to COPD and CV risk having a common risk factors of smoking. So there are various mechanisms by which one will perpetuate the others. So let's look at the biological pathways. The smoking, physical inactivity, diet plays a very important role in that. Uh, Certain air pollution exposures, and especially we have seen in the villages, there is so much pollution which is coming up with the biofire and biofuel, which has been attributed to the obstructive airway disease. So there are various mechanisms, various parameters of inflammation which come into play, like TNF alpha, interleukin 6, CRP, fibrinogen, and of course the age, as the age advances, there are the phenomena which will happen, like a telomere shortening, cellular senescence, and reduced cell proliferation, which can add to COPD, that is emphysema and chronic bronchitis, and cardiovascular disease. So you have various conditions in the form of acute MI, angina, stroke, peripheral arterial disease, congestive heart failure, cardiac arrhythmias, of course, which would be one thing which will be contributing to it. Now, the mechanisms by which COPD will increase the risk of cardiovascular disease. I already mentioned about especially hypoxia and hypercapnia, which can lead to oxidative stress, endothelial dysfunction, and worsening of arterial stiffness. On and above, the bronchodilators, like we are going to discuss, that will can have also a role, and can, like how we saw in our patient, has got led to arrhythmias also. And similarly, vice versa, let me not displease my chest physician partners. I would also admit that our drugs of cardiovascular disease medications also has an impact on the COPD, whether we talk of ACE inhibitors or antiplatelet agents. So it's a vice versa. Now, how do we go about assessment of such patients' comorbid conditions, and how do we go about the pharmacological management of these two conditions, that is COPD and cardiovascular disease? So this is a very, very crucial thing which we have to keep it in mind. And I would take each condition separately. Like somebody who is stable COPD, how should you go as a family physician, keeping that parameters in mind? So don't just think that he is an isolated COPD. You should be knowing that, let me look out for, are there any associated comorbidities which has not been manifested up till now? So you need to do a clinical assessment and functional assessment. So a thorough, detailed history and physical examination, which is absolutely recommended. Whether you apply whichever chart you want to apply, there are certain questionnaires, modified medical research council, or COPD assessment test, or whichever, but you need to do a thorough, detailed history and a physical examination. Of course, the lab assessments, which includes the routine test, biochemistry, that is CBC, plus ABG, a baseline. Now, this is something which is very, very important. I cannot over stressed on it, but a baseline ABG, or arterial blood gas, which definitely needs to be done in all COPD patients, because that will quantify what is the baseline status of the blood gases, because if he worsens, then we should know what is the situation. Of course, it's certain situations you need to get a CRP, anti-proBNP. Spirometry, which has been somehow underused. Spirometry is the method by which you are going to detect, diagnose somebody with a COPD, and you should have a baseline spirometry. And if need be, DLCO, so static lung volumes and carbon monoxide diffusion capacity, chest x-ray, and of course the ECG, which becomes a mandatory. So even if is a COPD, patient, it's not just chest x-ray, but you need to have a 12 lead ECG done. Now coming the other way, somebody who is a known cardiac disease and presenting to you for routine follow-up, don't just think he is a cardiac conditions and you should not look for other risk factors for COPD. So you should definitely evaluate from that risk point of view and need to find out what is his functional assessment, which also needs to be done. So this is the proposed algorithm for CVD in a stable COPD. So, as I mentioned, there are symptoms can be common, risk factors are common. Now, in a patients with COPD, you must do ECG and echocardiogram. If you see a baseline, again, as said ECG, but maybe intermittently you must have an echo done, because echo will tell so many other findings. So it is not just to detect pulmonary hypertension, but it will also tell is there any regional wall motion abnormalities are there, is there any associated right ventricular dysfunction, so many things which can be found out on it. Okay, so that would be, plus if it shows regional wall motion abnormality, it will confirm your diagnosis of cardiovascular disease. uh, in a patients with cardiovascular disease, also you should do a spirometry. So why I'm saying once in a while you should do and pre and post bronchodilation, and you can confirm COPD whether it is there or not, so that you can optimize the treatment for cardiovascular disease and COPD, which can be well done over here. So now, somebody who is a known COPD and coming with an acute exacerbation. Now, there is a trick or there is a catch. So, obviously, for all practical purpose, you will think that it is an acute exacerbation of COPD. So, you will do all standard tests, but you also need to look into that whether has he got underlying cardiovascular disease, because there could be both pathologies coexisting. The person can have a decompensated cardiac disease, or there could be a underlying infection, or there could be some other concomitant diagnosis. So don't just think that COPD presenting with acute breathlessness is always acute exacerbation of COPD. So we need to evaluate them well. So both conditions need to be simultaneously addressed, because the constant two-way interaction of dysfunctional mechanisms needs to be addressed, and you can give a better outcome for these patients. Now, again, showing you one another ECG with somebody who is presenting with acute exacerbation when patients with underlying COPD. So obviously tachycardia would be a common phenomena would be there. You can look at the axis, you can look at the P pulmonal, which will again tell, if you see the lead 2, which is showing tall, is the tall P waves, which is a P pulmonal. There is a clockwise rotation of the heart, and of course the left low voltage and left sided leads, which are seen over here. So somebody who is presenting acutely, so there could be a two possibility, as I was mentioning. It could be acute exacerbation of COPD in a patient with underlying cardiovascular disease, or it could be an acute cardiovascular event, or what we call as acute coronary event in a patient with COPD. So first level, of course, we do the routine test. You need to do it. You need to do troponin I and NT-proBNP. Now, let me tell you one important point over here. You know, if it is a acute coronary event with failure, okay, and if it is not acute exacerbation COPD, unnecessary usage of antibiotics can be avoided. In fact, there is data which shows that antibiotics given in those patients increases the risk of mortality. So when it is not indicated, you should avoid, and you can easily avoid it. Of course, the second level assessment would be, if the need be, D-dimer, echo, and a CT chest to look for any underlying consolidation. In COVID time, HRCT has become a very popular thing. In fact, I was surprised. What we learned is that the radiologists were saying that now, earlier we hardly used to get HRCT, which has been proposed or recommended by family physician. Now it has been recommended or advocated left, right, and center, because probably they have understood that it has a value. But again, let me tell you, it should not be overused also. And of course, the treatment should be according to the recommendations. Coming to the pharmacological management, the treatment of cardiovascular conditions in a patient with COPD is always associated with a therapeutic challenge, because there are two issues. You are co-administering beta 1 blockers, selective beta 1 blockers, and you are giving beta 2 agonist in an inhaled form. So one side you are giving agonist, one side you are giving blockers, but of course at the different levels. And beta blockers, which are very close to any physician cardiologist heart, it's a widely prescribed treatment in cardiovascular disease. And also now, let me tell you, it has also been well accepted in COPD. We will come to that, why that we will discuss it over here. Now, at the same time, beta agonist, which represents again a cornerstone of COPD treatment. So these two have opposing pharmacologic actions, and we need to take care because the one may worsen the other. So let's look at the respiratory drugs in CVD patients. So there is a short-acting beta agonist, what we call SABAs, and long-acting beta agonist, which are called LABAs. I'm sure you have heard of it. Now, in various clinical trials, we know that beta 2 agonist, which has a side effect in the form of increasing the heart rate, reducing potassium concentration, and both these conditions can increase the risk of CV events. Now, due to the beta 2 adrenergic action, SABAs, that is short-acting beta agonist, can precipitate atrial fibrillation, which, as if you remember, which we discussed in our case, and can hamper the control of ventricular response. Long-acting beta agonists have been associated with increased risk of CV events. Now, that is something which we need to understand, and why. It can be due to stimulation of sympathetic drive, and which can also increase the risk of various arrhythmias, oxygen demand increases, myocardial ischemia, and as a result of which the increased incidence of heart failure. Now, another class of agent, that is LAMAs, that is long-acting muscarinic antagonist. Now, these agents suppresses parasympathetic control of heart rate, again, which can increase the risk of tachyarrhythmias. But there are various potential mechanisms whereby these drugs could even lower CV risk by reducing the lung hyperinflation. Now, this is a beautiful paper published in JAMA about the association of CV risk with inhaled long-acting bronchodilators in patients with COPD. And it has been shown over here in this duration response curve, cardiovascular risk, that new use of LABAs or LAMAs was associated with 1.5-fold increased CV risk in a patients of COPD within 30 days of therapy initiation. Now that is something, you are talking of directly 1.5 times risk of an event, which is significant also. Coming to xanthine derivatives, of course, my dear friend Parthiv is going to discuss about it, of which there are pros and cons. I would not discuss into this matter right now. So what I wanted to tell you that there are arrhythmias which are associated with new use of bronchodilators, whether we talk about ipratropium, SABA, methylxanthines, or LABAs, which has been there. So both short and long acting beta agonist may be associated with a modest increase in the risk of cardiac arrhythmias in patients with COPDs. Inhalation corticosteroids, which are not used as monotherapy in COPD patients, the safety data are less robust. The only thing, there is one interesting study, Summit study, which has demonstrated that the incidence of MI and unstable angina did not differ significantly in groups of COPD patients with increased CV risk treated with a combination of ICS and LABA. So that is one thing which is there. Now coming to other aspects about antiplatelet agents and anticoagulants. So now I'm talking about the CV drugs. We talked about respiratory drugs, which has an impact on heart. Now talking about CV drugs, which has an impact in COPD patients. So commonest use antiplatelet agents, anticoagulants. Now, according to the available evidence, this is something which is really a new theory which is coming up, that antiplatelet therapy has been associated with a reduced 1 year mortality in patients with hospital admission due to acute exacerbation of underlying COPD. So if this will come, obviously it will come as a standard recommendation now, which we have to see. So because there is a significant reduction of mortality in COPD patients if they are treated with antiplatelet agents also. Talking about AC inhibitors and ARBs, which are again commonly used therapies in cardiovascular segment, which has an impact on the COPD patient. So RAS has been implicated in various processes in the lung, renin, angiotensin, aldosterone system, and that may be important again in the pathogenesis of COPD. Now, the data on the effects of RAS inhibitors, whether we talk of ACE inhibitors or ARB, on the especially in patients with COPD are limited. Of course, there are few studies have shown that there could be a potential benefit on pulmonary function and hemodynamics. But unfortunately, the side effect of ACE inhibitor, which is a cough, which has been issue, which is there has been some data about worsening airflow obstruction, again associated with AC inhibitor, not with ARBs. So data always shows ARBs are a better choice for patients with COPD requiring treatment of RAS blockade compared to AC inhibitors. Beta blockers, I already mentioned about it. How do we go about it? So obviously given the mechanisms, beta 1 selective antagonist, which potentially exhibit a small degree of dose related beta 2 receptor blockade. So you need to go for selective beta 1 blockers, which are definitely preferred also. Now, there has been now enough data which is showing that beta blockers, if used selective ones, does not cause worsening of bronchospasm, or even data which shows that 30-day readmission or worsening of COPD patients is not happening. So the cardioselective beta blockers in COPD patients seems to be safe and may be suggested if indicated from cardiovascular disease point of view per se. Because earlier, whenever we used to write a chest physician, when they will see the patient, they would say omit beta blockers. But now this data is very clear. So ladies and gentlemen, to conclude, COPD and CVD are complex disorders that frequently coexist and are associated with worse outcome than either conditions alone. Reduced pulmonary function in COPD is associated with increased incidence of all-cause mortality, cardiovascular disease-related mortality like and MI and arrhythmias. Beta 2 agonist and theophylline should be administered with caution if they aggravate AF, that is atrial fibrillation, or impair the control of ventricular contraction frequency. They should be stopped as and when needed. And the current guidelines offer only limited recommendation for the management of CVD in patients with COPD, and there is a need for more extensive and specific recommendation to guide physicians in clinical practice. So I would end with the quote from Sir Isaac Newton, that what we know is a drop, what we don't know is an ocean. And that is so much true when it comes to a subject when we know CVD and COPD management together in an individual patient. Thank you so much for the patient hearing. And now we would take up the questions at the end. And I would now would definitely, yes, the our star speaker has arrived from Lucknow. So Professor Dr. Suryakant sir, who has already been introduced. Welcome, Dr. Suryakant sir. It's always a pleasure. And of course, though Dr. Suryakant sir has been introduced uh, to this audience, we have this IMA crowd. Let me tell you, sir is the national vice chairman of IMA AMS. He is very actively involved in academic activities. And I must say, whenever I have invited at any forum, we have invited at Academy of Advanced Medical Education, we have invited him at Indian Medical Association, we have invited him for a crosstalk in Indian Society of Electrocardiology, wherever he is there with us. So I welcome Professor Dr. Suryakant sir and would request he would be talking about concomitant asthma with allergic rhinitis, case-based approach and management. Friends, whatever the queries, questions related to all the talks, we will have it at the end. Discussion will be having it. And with these words, I hand over to Dr. Suryakant sir. Thank you.
Thank you, Ketan. A very good morning to all of you. Sorry if I'm being late. You see, this is the usual practice and usual mindset that any webinar or seminar will be in the evening time. So that was the mindset. Sorry, I just forget. And of course, Priyam reminded me. Thank you, Priyam, for reminding me on time. So then I borrowed half an hour. Then I said that just do one favor, just ask the Ketan to have his presentation. And then of course, the next one can be mine. So thank you very much. And a very good evening to all my IMA fraternity from the Mumbai West. So we are on the same boat of the Indian Medical Association. Although everybody knows, but Indian Medical Association is the largest medical professional body in the world. Not only in Asia or in India, it has got membership of around 4 lakhs doctors of modern medicine. And we should be proud of that 2 our Indian doctors, they have been the president of World Medical Association. So we are the world leader in the medical field. We are, of course, now in last 2 years, we are COVID leaders also, because India is the only country where we have controlled COVID effectively. And still some countries, they are facing challenges regarding the COVID management. And countries with a lot of infrastructure, health infrastructure and health facilities and more number of doctors population ratio, they have faced a lot of challenges, but India could manage in a far better way. So kudos to all of you. Congratulations to all of you who are present in this webinar. So with this background of IMA, coming to my topic, given me by Dr. Mehta and of course IMA Mumbai West, the concomitant asthma with allergic rhinitis. Usually if you go in the mall and there is a scheme called Ek ke Saath Ek Free. So probably Dr. Ketan has also, you applied the same formula to me. The allergic rhinitis is free with asthma. So anyway, this is my package, Ek ke Saath Ek Free, asthma ke saath allergic rhinitis free. Anyway, the scheme is given by Dr. Ketan. Thank you, Ketan, for wonderful, benefiting your IMA fraternity of Mumbai West. Anyway, if you see the journey of asthma, it goes way back to 2,500 years back. Yes, goes to father of modern medicine, Hippocrates, who first described asthma as panting or gasping. This is the clinical picture which he described, and he turned this he coined this term from a Greek term called asthmeneo. Asthmeneo is basically Greek term which means panting or gasping, that was described by Hippocrates around 2,500 years back. So it is the description of asthma which is first a recorded evidence that, of course, available from Hippocrates onwards. You see, I will give you one disclaimer here. Usually books describe Hippocrates as father of medicine. I do not agree with this. Why I'm giving disclaimer? If we say that Hippocrates is the father of medicine, it means there was no medicine before Hippocrates, which is not true. You should be proud enough to be Indian physician that there was a medicine, maybe different kind of medicine that may be debatable, but there was a medicine. Not only in India, there was a medicine in Russia, medicine in China, medicine in Arab, medicine in so many other countries before Hippocrates also. So we cannot say that Hippocrates was the father of medicine. I would say Hippocrates is to be considered as father of modern medicine, to which we belong. The first etiological link of the allergic rhinitis and asthma as the topic is given by none other than Galen in 2nd century. So the link of allergic rhinitis and bronchial asthma is around 2000 years old when it was established by, or rather proposed by, Galen in the 2nd century AD. And of course, there is a concept of occupational asthma, link between the environmental factor and asthma, that was proposed by Georgius, and Georgius is in the 15th century who first gave the report of occupational asthma, establishing the link between the environment and airway symptoms. Then, of course, the concept of extrinsic asthma and intrinsic asthma, means allergic asthma and non-allergic asthma, that is called in medical terminology as extrinsic asthma and intrinsic asthma. It was given by Henry in 19th century, so it was around 200 years back. And they also suspected involvement of neural and vascular mechanism behind the asthma pathogenesis and pathology. And then comes the 19th century, the great scientist, Sir William Osler, who explained the emergence of concept of airway inflammation and airway hyperresponsiveness that is supposed to be the modern concept for the pathogenesis of bronchial asthma. With this historical perspective, I'm coming to next thing about the asthma. What is how this asthma has evolved, the pathogenesis has evolved in last 50 years. In last 50 years, there is a revolutionary changes in the understanding of asthma has occurred. In 1970s, if you see our seniors, the doctors who are having 50 years plus practice, they were taught during their MBBS days that asthma is a basically disease of bronchospasm. That's all finished. But later on, when 1980s, then concept of bronchospasm plus inflammation came. And then came our era when we were the MD student in 1990s. And I think the most of us belong to this era, the middle order batsmen, we can say. So there is a concept of bronchospasm, inflammation, and airway remodeling. If you don't treat asthma properly, then asthma, the airways becomes stiff. This is called airway remodeling. So we as a MD student in 1991, 92, we of course read this concept during our MD days. And then of course the present treatment is completely revolutionized treatment that consists of biomarkers, personalized treatment, interleukins, you see the biological markers, use of biological for the treatment of chronic persistent asthma and severe asthma. So a lot of, you have to differentiate whether this is eosinophilic asthma, neutrophilic asthma, allergic asthma, and then only you can decide the biological. So different kind of concept they have come. So how drugs they have been involved. As a IMA member, you must know, because history gives a lot of idea regarding the anything. There's maybe history of a country, history of a medicine, history of anything. Even in your family history, family tree, you must know your family tree. That's also important, gives you so many things in your life. So first drug came into existence and is still being practiced is the theophylline and short-acting beta-2 agonist, as Dr. Ketan was mentioning in the lecture of COPD with link with the cardiovascular diseases. So this is the short-acting beta-2 agonist, and popularly we call it as SABA. And then, of course, the most important drug used nowadays is inhaled corticosteroid. And the concept of inhaled corticosteroid came into 1972, around 50 years back. And then, of course, the from short-acting beta-2 agonist, the concept of long-acting beta-2 agonist came in 1995. And then, of course, very important anti-allergic drug, which is used for allergic rhinitis, although and bronchial asthma also. The molnupiravir came in 1998, which is roughly around 24-25 years back. And then came the ideal therapy of the modern asthma management, the combination of LABA plus ICM, means long-acting beta-2 agonist, means a long-acting bronchodilator, plus inhaled corticosteroid, and all are in the inhalation form. Now, there is no place of oral therapy in the management of bronchial asthma. The debate was during the 90s and onwards, how should we treat with oral drugs or inhalation drugs. Now this debate is over. So what is the ideal treatment of asthma? It is the inhalation therapy. What is the ideal drug for the treatment of bronchial asthma? Now it is, yes, inhaled corticosteroids. Rather, to be very precise now, ICS-LABA combination is the drug of choice, which is called SMART therapy. So once daily ICS-LABA, this is called ICS SMART therapy, a combination of ICS-LABA in a single inhaler. And of course, then add-on therapies like the LAMA, which is a drug of choice for COPD. If there is a severe asthma, means airway remodeling has occurred, you can switch over to even add-on therapy. And one of the add-on therapies, LAVA, then of course, biological in the form of interleukin 5, monoclonal antibodies, altropium, and so many others. Now, with this background, historical backgrounds, what is the definition of asthma? Everybody knows it's a heterogeneous disease characterized by variable respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough, and variable expiratory airflow limitation, usually associated with airway inflammation. And if you see the epidemiology of the asthma, then around 26 crore people suffering globally in asthma in 2019, with around more than 3.79 crore people in India. 37.9 million means more than 3 crore. That is 3.79 million, almost 3.8 crores in India, and caused the 461,000 deaths globally. And that is not important. What is important is India is first. India is on top. Total number of asthma cases, number 1. In total dailies lost, number 2, and for total asthma death. What is alarming in India is because of the poor type of management of asthma, the mortality in asthma, which is not a good thing, rather, which is not a common globally, it is common here in this country. 43% of the all global asthma deaths, they are occurring in our country, and that's very challenging. So this is my professional, moral, and ethical duty to train my all IMA colleagues for the treatment of asthma, because India don't have such pulmonologists in this country, so that all asthmatic, they should go pulmonologists. For example, all eye surgery is being done by ophthalmologists, all ENT surgeries are being done by ENT people, but all asthma and COPD cases cannot be treated by only respiratory specialists or pulmonologists. So it is my humble, professional, ethical, what do you say, it's a duty to sensitize, to do capacity building of my all AMA colleagues, which are 4 lakhs number in this country, to diagnose asthma, to treat asthma at their own level. And so that we can reduce the mortality and serve the humanity by reducing the mortality, that is the 43% of the global share. So what is bronchial asthma? As a concept slide, I love this slide. This is the asthma is the result of the genetic constitution and your environmental, of course, factors. Now, there is a genetic susceptibility, and then there is a certain environment factor, an interaction occurs, and that's why asthma manifests. So a person born with the asthma susceptibility does not mean he's asthmatic, but whenever there is an interaction between this genetic susceptibility of the airways with this environmental factor, then there is a chronic inflammation in the airways, then there is a bronchospasm, and then of course patient is having symptoms of episodic breathlessness, chest tightness, cough, and chest tightness and shortness of breath. So that's why most of the time we are also getting family history. Around 50% cases of asthma, they are also having family history. Now, this is my UC public domain slide. I am really sorry that for the IMA, I have brought this very concept slide of, but I love this slide. This slide is basically for my asthma lecture in the public domain, in the school children or some other forums. Anyway, if you touch the leaves of any plant of the universe, nothing will happen except one situation where if you touch the leaves of touch me not plant, in Hindi, in Uttar Pradesh, we call chui mui ka pauda. I don't know what in Marathi you call it. But if you touch this plant, the leaves of the plant, what will happen? The leaves will shrink. This is happening only with these leaves because of the genetic susceptibility of these leaves with the touch. And similarly, the airways, the bronchi of an asthmatic individual, they are genetically susceptible for the certain environmental factors. Of course, those are called as the triggers or the factors for the asthma provocation. And that is how asthma pathogenesis and pathology occurs and manifestation occur. Now, what are the major risk factors with which a genetically susceptible individual interact and then asthma develops? So the major risk factor for asthma are the family history of asthma, number one, and atopy means allergy, any allergic disorder in the childhood, allergic allergic rhinitis, skin allergy, food allergy, any type of allergy present in a child. Suppose you are a pediatrician or general physician, if a child coming to you repeatedly with the symptoms of allergy, first time food allergy, then skin allergy, then of course allergy of the nose, you think of that this is the child who's a potential future candidate of bronchial asthma. So have a look, have a vision from this early childhood that this patient might develop bronchial asthma in future. Tobacco smoke, you see, smoking is risk factor for so many diseases. And this tobacco kills around 12 lakhs people per year in this country. And that's why it's a very important risk factor for asthma also. Outdoor and indoor air pollution, biomass exposure, combustion of solid fuel. And thanks to our Prime Minister Narendra Modi ji, who started a very important scheme that is called Ujjwala Yojana. Ujjwala schemes, it was started on the 1st May 2016 from a district of Uttar Pradesh, Balia. And now the Ujjwala 2 also rolled out with the success of the Ujjwala 1. Until date, more than 9 crore poor family of this country, they have been given a free connection of LPG as a clean fuel for cooking. And now slowly and slowly, this biomass exposure factor in this country is going down. And of course, thanks to our Prime Minister. Respiratory syncytial virus and para-influenza virus infection, they are another factor, and this is the seizure of virus. I used to say, whenever there's a rain, there is a seizure of virus. I don't know what rain. You see, rain has got so many, factors. You see, there are so many lovers who love the rain. There's so many love stories they started in rain. So many pictures they have been shooting in the rain. Mumbai is your city of the Bollywood, and so many pictures have been shooted in the rain. So rain has got multi-fold effect, and one of them is the virus. And we are having a lot of viral infection in now Uttar Pradesh. I don't know what's happening in Mumbai and Maharashtra. Occupational exposure. India has got, variable occupations. You see, the Western world cannot imagine, rather, I would say, how many types of occupations India have. In every street, there is occupation. Every city has got different type of occupation. And there are a lot of occupations which raise the noxious particles, gases, toxins, fumes, so many things. I'm not talking of industry. I'm talking of local, the occupations. So we have to take the history of different occupations as per the local regional profile of the occupation. I don't know what type of occupations are different. They are different from Uttar Pradesh and Maharashtra. They are entirely different. Even in Uttar Pradesh, there are so many pockets. If you go within 100, 200 kilometers, the type of occupations will change. For example, one of the city in Uttar Pradesh is Firozabad, is known for the glass industry. The Bengal industry, the Malayan jo churiyan pehenti hai, the Bengal industry, every street is having the Bengal industry inside their street. And ladies, they are involved in that process, and a lot of air pollution, a lot of occupational, toxins, fumes, they are emitting, and they are, of course, ladies are exposed for the hazards of. There are, of course, the associated comorbidities. And again, I would say, what is the most common comorbidity with asthma? It is my dear friend, allergic rhinitis. So you have to, whenever you take the history of asthma, whenever you see the patient of the first thing which you come in mind as a comorbid condition is the allergic rhinitis. I think probably that's why Dr. Ketan has kept this package of asthma with allergic rhinitis. Again, this is the slide which I have kept from my MBBS final year class. I'm really sorry again that I'm showing you some public domain slide and some my MBBS final year slide. I don't want to underestimate your using knowledge, skills, everything, but this is my pleasant duty to refresh the button of MBBS days. So that's why I have kept this slide also. I love this slide again. What is the pathology and pathogenesis of the? In a single slide, I used to explain my MBBS final year student that learn ABC and you are well aware of the understanding of asthma. A stands for airway hyperresponsiveness, B stands for the bronchoconstriction, and C stands for chronic inflammation. And you can see the cut section of the first normal tube without asthma, and the second where lumen is narrowed down because of mucus inflammation, muscle hypertrophy of the airway, so many things. And so these are the cut section of air tubes or bronchi with asthma. What are the clinical challenges in the management of asthma? Number one, majority of Indian patients remain undiagnosed or wrongly diagnosed. Yes, this is still true. Those who get diagnosed remain poorly or inadequately treated. I'll explain you later that only 36% of Indian asthmatic patients, they are on proper inhalation therapy. Only 36%, means every third. Means 3 out of 3, 2 are not properly treated in this country. Most of the Indian patients continue to be on oral medications rather than inhalation therapy. And this is the real challenge, not for Dr. Surikant, not for Dr. Ketan Mehta. This is the challenge, not for Dr. Parthe Mehta. This is the real challenge for the IMA also. Because IMA is the largest professional body with the 4 lakh membership, as I mentioned in the intro. Now, see, this is our commitment, the IMA. You will be surprised to know that current IMA All India Honorable General Secretary, HGS of the IMA headquarters, the national leader of IMA, who is from your city, Mumbai. So Dr. Jayesh Lele is also co-author in this article with us. Dr. S.K. Jindal is the leading pulmonologist of the country from PGI Chandigarh. He has retired from PGI Chandigarh. Dr. J. Lele, means Jayesh Lele, is the second author, and the Lady Ghoshal from Kolkata, Sanjeev Nair is from Kerala, and Dr. Surikant S. Kant is from Lucknow. So these are the few authors who wrote an article published in 2020, just 2 years back. And this is the executive summary of the recommendation on management of asthma in primary care, in which we have mentioned how a primary care physician like a doctor can manage the asthma. You just go through this article. If you have missed my lecture on this forum, of course, probably this lecture is being recorded. You can take the recording from Dr. Priyam or Dr. Parthe, Dr. Ketan. And of course, if you don't have the access to this lecture, you can go through this article published in the Journal of IMA, JIMA. Yes, all of you, this is my sincere advice, being in the advisory board of the JIMA, that this is please always have because JIMA is available now online also. So have the access to the JIMA. And if any problem, please let me know, or you can let they know the Nandini Chakravarti of who is the editor from Kolkata, or Jyotirmay Paul. Anybody you can contact if you're not getting the journal access, either the hard copy or the online copy. You must read the JIMA. At least one journal you must read as a member of IMA. That is Journal of IMA. It is the complete journal having all the subjects inclusive in this single issue. So from orthopedic surgery, everything is included, and this is coming monthly, my dear. So don't wait for 3 months. Every month you are getting, and on the 28th of month it is available online. If you are on the just check on 20th October, it will be available for the month of October. So my all now PPTs will be based on this publication. Now, this is my nice view of addressing the asthma. When I usually address the API forum, GP forum, or IMA forum, this is my favorite slide. Recently, I gave the lecture in Jhansi, one of the important city, Jhansi ki Rani Lakshmibai, aapne suna hoga, one of the important city of Uttar Pradesh, where I delivered the same approach lecture. This slide is not evidence-based. If you search what is the 7D approach for asthma management, you will not get anything in the internet, YouTube, or whatever it is. This is my personal way of teaching the people how they remember the treatment of asthma. First D is the doctor, second is the diagnosis and differential diagnosis, third D is the drugs, fourth is more important, doses of the drugs, and most important, the device, which device you should use for the inhaler. And deliberation is the patient education. Adherence therapy is very important because just simply prescription will not provide relief until it is adhered to the treatment. Now, first, doctor, how asthma doctor should be. Yes, at the end of this lecture, you will be an asthma doctor. You will be trained asthma doctor. This is my guarantee. You just listen carefully and you will be trained asthma doctor. Of course, so you should have a very good literature that is suitable to you and not like this. So diagnosis, how you diagnose, very important. This table is from the same publication, June 2020. That you should take the history of variable respiratory symptom, as I suggested in the definition, breathlessness, wheeze, cough, and chest tightness. And if more than one type of respiratory symptom present, variable symptoms occur over time and intensity. Symptoms often worse at the night or on waking. Symptoms often triggered by exercise, laughter, allergens, cold air exposure. Symptoms often appear or worsen with the viral infection. So if such thing is, then of course confirm with the pulmonary function. If at all you are having the facility, but is still in 2022, on 9th of October 22, I'm delivering this lecture on asthma, and I'm saying is still the asthma is a clinical diagnosis. You require one stethoscope, that's all, and you require the skillful history taking of the patient, that's all. This is the algorithm. You are finding the typical asthma symptom. If yes, and then of course take the history, physical examination, supportive of asthma diagnosis, family history, occupational history, and so many things, history of comorbid conditions. So other diagnosis unlikely, you treat like asthma. If no, then of course confirmation of alternative diagnosis if you can make. If no, and if yes, then of course alternative diagnosis. If no, then of course repeat the test. And the same thing is clinical history, the other related history, physical examination, and pulmonary function. Only 4 components are there to reach at the diagnosis of asthma. Now, how you differentiate the various important differential diagnoses. So these are the 5 important mimics of asthma, or 5 important differential diagnosis of asthma, and how will you differentiate? For COPD, as taught by Dr. Karthik just now, Dr. Ketan just now, the cough, sputum, dyspnea on exertion, smoking or noxious exposure is important in COPD. GERD, gastroesophageal reflux disease, that can also mimic asthma, but usually there is a history of heartburn, usually after eating and worse at night. Bronchiectasis, productive cough, large amount of cough, recurrent infections. Cardiac failure, which is also called as cardiac asthma. Dyspnea with exertion, nocturnal symptoms, swelling, edema in legs, ankle and feet, rapid or irregular heartbeat. So, and of course, ECG, echo are the additional investigation which we can do. And very important, how will you differentiate between asthma and COPD? I will not go into the detail. The only thing is just look on the patient. First 2 are the asthmatics, and second one is the COPD patient. What are you observing here? The chest remain, first is asthma, and second and third are COPD 2 phenotypes. The first, if you look the chest, just look the chest. By just inspection, you can differentiate whether this is asthma or COPD. Look the chest. Chest looking normal, it is asthma. Chest looking abnormal, it is not asthma, COPD. Both are having symptoms of dyspnea. Asthma is having usually symptoms starting from early childhood. Allergic rhinitis, food allergy, skin allergy, then breathlessness, and then of course asthma. Asthma has got episodic breathlessness. COPD is having chronic progressive breathlessness. Once dyspnea started, it will continue. In asthma, in July, your patient is dyspneic, August not. In October, again dyspneic. In March, again dyspneic. So this happens with asthma. Monday, he was dyspneic. Saturday, he was not dyspneic. So morning, he was dyspneic. Evening, he was not dyspneic. So this is called episodic breathlessness with asthma. But COPD, no. It is progressive dyspnea. Chest is normal, chest X-ray is normal in asthma. You see, you will not see. Rather, we advise chest X-ray peer view in patient of asthma just because you just rule out any other shadow. If there is no shadow, you are doubly ensured that yes, it is bronchial asthma, nothing else. And in COPD, you have two abnormal type of phenotypes. One is you can see the thin patient, another is thick patient or obese patient. So first, the middle picture is called the pink puffer or the pink puffer type of phenotype or mainly emphysematous disease. The third picture of COPD, this is different phenotype. This is called blue blotter or mainly chronic bronchitis disease. Because in third picture, most of the patient develops cor pulmonale, and that's why body is swollen. And in emphysema, the patient is usually dyspneic, and patient is severely dyspneic, having pursed lip breathing, and cachexia is there, and that is how you differentiate the two phenotypes of COPD. So just by looking on inspection, and what is the use of stethoscope in these two diseases? It's a very, very favorite topic. A stethoscope is useful asthma. It is not useful for COPD. Why I'm saying? If you put your stethoscope over the chest of the asthmatic patient, you will hear a lot of sound. This is called musical sound or bronchi. If you put your stethoscope over the chest of COPD, you will not hear anything. Breath sounds are diminished. So stetho is useful for both diseases as you are getting more sound in asthma, less sound in COPD, but it is said that auscultation is basically more helpful for the diagnosis of bronchial asthma as you are getting more and more sound. You are listening more and more sound. In COPD, you are not getting sounds, rather breath sounds are diminished. So that is the difference between the auscultatory finding. So inspection of auscultation, these are the two important clinical findings by which you can make the diagnosis of asthma or COPD. Very important to differentiate. Of course, comorbid condition. You see allergic rhinitis on top of the list. And of course, patient, they are also developing the polyps. Chronic sinusitis, GERD, obesity, obstructive sleep apnea, hormonal disturbances, atopic dermatitis, allergic bronchopulmonary aspergillosis is not only comorbidity, but it's a co-complication also. ABPA, in short, it is called ABPA. Bronchiectasis, hyperventilation, glottic dysfunction, psychopathology, smoking, nicotine dependence, COPD, associated COPD also, or asthma, COPD overlap, and repeated respiratory infection. So comorbidities may change the asthma phenotype. Treat condition appropriately to optimize asthma control. You cannot control asthma fully until you treat comorbid conditions with full, of course, treatment. As I mentioned, what you will get physical examination in asthma, bilateral diffuse bronchi or polyphonic view. So stethoscope is your most important tool for diagnosis of asthma. A word about spirometry. I know that most of you, as I am a member, as I am a practitioner, may not be aware of spirometry because I don't know the status of spirometry practice in Mumbai, but in Uttar Pradesh it is very poor. Even there, these few salient features of spirometry lung function are the evidence of obstruction, which is given by FEV1 FVC ratio, which is less than 70%. Post bronchodilator FEV1 is the increase in 200 ml and 12%. It is called suggestive of bronchial asthma. If you do peak expiratory flow rate, a small instrument, peak flow, in adults, the average daily diurnal peak expiratory flow variability is more than 10%. In children, it is more than 13%. So this is the instrument, very small instrument that costing around 400 or 500 rupees. Every physician, general physician, I'm a member, should have this small instrument, peak flow meter, if you want to really practice as respiratory practice, and if you really want to become an asthma doctor. Peak flow meter, it has got you see list there age as per the age and your weight, male and female. There is a chart. This chart have the expected value, and if you just ask the patient to blow it, and if it is reading coming in the green zone, means patient is safe, asthma is controlled or not having asthma. Yellow zone, yes, there is in danger, and red zone is fully danger, may be hospitalized within few days. So peak expiratory flow done on peak expiratory flow meter can be a good indicator for asthma diagnosis if it shows reversibility on bronchodilator medication. So do the test, give an inhalation bronchodilator, and repeat after 20 minutes. If it is more than 20% value, then it is suggestive of the asthma. Now, Another D is the drugs and of course the doses. So management of stable asthma, and I repeat again that only 36% of the Indian patients, they are on the controller inhaler, which is the best inhalation therapy. Inhaler route is safer as compared to oral or IV read. This is the evidence-based. Asthma medication in inhaled form should be considered as compared to systemic formulation to improve clinical outcomes in asthma. So what asthma medications we have? We have three types of asthma medication for treating asthma. Controller medications, reliever medications, and add-on controllers means therapy in severe asthma. So basically for non-severe asthma, which I would recommend that you can treat, everybody can treat for controller for the add-on for the severe asthma. Of course, you may require the expertise of Dr. Ketan Mehta, Parthiv Mehta, or Dr. Suryakant. Then, but yes, for the non-severe asthma, you can treat very well. So these are the three groups of medications. And asthma pathology, as I mentioned, this is the spasm and swelling. So spasm needs a reliever drug called bronchodilator. Swelling needs a preventer drug called the anti-inflammatory. Sava Lama are the bronchodilator therapy, and inhaled corticosteroids are the anti-inflammatory therapy. And this is the step-up approach for the asthma treatment, step 1 to step 5. But you see, you can step down also. So every 3 months, you review the patient if your asthma is well controlled, and you can try to step down. So in the lowest possible step, you can maintain the asthma. In step 1, ICS LAMA. You see now the inhaled corticosteroid plus LAMA means long-acting muscarinic acid, long-acting LAMA, long-acting beta-2 agonist. This is the drug of choice for any step of asthma, from step 1 to step 5. You can increase the dose of inhaled corticosteroid to medium in step 4 and high in step 5. Otherwise, from step 1 to step 3, you can treat the patient with low dose of inhaled corticosteroids. What are the low dose, medium dose, high dose? I'll just tell you. And then our SOS beta-2 means salbutamol or levosalbutamol. They should be treated. They should be given on SOS basis. In group 5, add-on therapy can be given, which we will discuss later on. So these are the controller medications. Three types of controller medications we have: inhaled corticosteroid, the montelukast you can use also orally, and then of course the combinations. But inhaled corticosteroid, beclomethasone, budesonide, so many inhaled corticosteroids are available, and they're also available in combination with the LABA, which is the ideal prescription for the asthma: beclomethasone, formoterol, budesonide, formoterol, etc. And then we have a reliever, the SAVA, and of course the LABA, the salbutamol, tributylene, short-acting SAMA can also be used as short-acting muscarinic agent or cholinergic agent. That is ectratropine bromide. And there are low ICS, and the LABA combination can also be used as a reliever medication. So you have a very good choice: beclomethasone plus formoterol, budesonide plus formoterol. And then what is the story of preventers? Any patient who is on regular inhaled corticosteroid therapy will lead the life like this on regular preventer. And occasionally means we take the inhaler SOS basis, or often. Usually patient says, sir, asthma ठीक हो गया था, तो मैंने सोचा थोड़े दिन बंद करके देखूं. Don't do it. I said asthma is a good friend. Asthma is like a speck. मेरे चश्मा लग गया, मैं चश्मा लगाता हूँ. अभी तो नहीं है कि मैं मंडे चश्मा लगाता हूँ, संडे चश्मा लगाता हूँ, मॉर्निंग चश्मा लगाता हूँ. अरे भाई, सुबह उठता हूँ, सबसे पहले चश्मा ही लगाता हूँ, क्योंकि बीवी का चेहरा देखना होता है और अखबार पढ़ना होता है, तो सब कोई सुबह लगाता है. So inhaler is also like this. It is all asthmatics are requested to incorporate into the lifestyle, like their daily brushing, bathing, taking breakfast, taking clothes, going office, whatever it is. So add-on therapy. If the patient is having still persistent symptoms, in spite of step 5 treatment, means high dose inhaled corticosteroid plus LABA, then it is called severe asthma, and then you require of course, the add-on treatment. So what add-on treatment we have? So we have if the child is more than 6 years, you can use tiotropium. If your child is more than 6 years, you can also use biological like mepolizumab. And then if your patient is more than 12 years, you can use mepolizumab. More than 18 years, rasnizumab. More than 12 years, benralizumab. More than 12 years, duvakitug. And systemic corticosteroid can also be used in a short duration period. They should not be used for a longer period because they are having more side effect if they use more than 2 weeks. But my recommendation is that if you are a not MD medicine or MD chest, please don't use these biologicals. This is the domain of the specialist. Refer to, of course, and this is, I mentioned low dose, medium dose, and high dose, of course, the steroids, different doses. Remember one thing, the budesonide, 200 to 400 microgram per day is the low dose, 400 to 800 is the medium dose, and more than 800 microgram per day is the high dose. Low dose you will use in step 1 to step 3, medium dose in step 4, and high dose in step 5. What devices? Now, question is whether you use this dry powder inhaler or inhaler with a spacer. What you will use? So, you see, I'm using the. This is my personal slide again. For last 20 years, I have modified year after year, but this is my current recommendation as a protocol of Department of Respiratory Medicine at King George Medical University, Lucknow. This protocol developed by me, and we are practicing for more than 10 years. Personally, I'm using 10 years, but as a protocol, when I become head of department, then I use this protocol for more than 10 years. So if your child is 0 to 3 years, then use PMDI, means pressure meter dose inhaler with the spacer, with the face mask or baby mask, or alternatively, you can nebulizer. So it is up to the pediatrician what they want, nebulizer or MDI plus a spacer plus baby mask. If the child is 3 to 6 years, then of course MDI with a spacer. 6 to 60 years, then we are using here dry powder inhaler or breath actuated. What is the breath actuated inhaler? You have heard so many inhaler which you just inhale and a click sound will come and an actuation occurs. They are called breath actuated inhaler. I will not speak any trade name, pharmaceutical, the pharma name, because it is against the ethics. Otherwise, you know very well. A lot of companies have come with this breath actuated inhaler. And then if more than 60 years, the MDI plus a spacer or breath actuated inhaler or nebulizer. So that is my recommendation for you, how to choose a device. Deliberation, very important. You don't talk the patient will not come to you. डॉक्टर साहब तो सुनते ही नहीं है, उनके पास टाइम ही नहीं है, जाओ तो व्हाट्सएप देखते रहते हैं. So this kind of situation will not happen. Patient education, asthma education is a part and parcel of asthma management. Before advising inhaled therapy, you must convince the patient, provide emphasis on compliance and adherence to therapy. So adherence is a very old issue, but problem is this, that we are not having control asthma in India. 40% are uncontrolled and partially controlled. 60%, no percentage well controlled. So we have to, of course, give the best treatment for asthma patients so that we can convert our patient into the well controlled asthma. And you see a little bit about how to select the biological. This is for MD medicine or MD chest who are on the of course this webinar. That very simple one slide I have given in that publication, how to select a biological for asthma phenotypes. If it is severe allergic asthma, means serum Ig is raised, use the anti-Ig omalizumab. If it is eosinophilic asthma, means peripheral blood eosinophilia is more than 300 or sputum eosinophilia is significantly present, then use the anti-interleukin 5 or anti-interleukin 5R, means mepolizumab or benralizumab, or you can use anti-leukin 4R, that is dupilumab. If it is not, serum Ig is not raised, eosinophils are not raised, neutrophils are raised, or neutrophilic asthma, then of course no biological will work on the neutrophilic asthma. Then you have to refer the patient to higher center for bronchial thermoplasty, or you have to use long-term macrolides. So these are the ultimate slide, single slide, very simplified slide prepared by me for how to go ahead using the biological. I will not go into the detail of bronchial thermoplasty. This is the procedure where a lot of bronchial muscle thickening has occurred, and with the heat energy, we cut down the muscles, the muscle mass, and we of course we increase the bronchial space. That is how bronchial thermoplasty done. This is the 4-point question: how we assess the asthma control, whether our asthma is well controlled, partly controlled, or uncontrolled. And this is the case, one case. I'm in the last part of my lecture. 32-year male, woman presented with the chief complaint of breathlessness on exertions in last 6 months with on and off cough without expectation, no history of orthopnea, fever, weight loss, no history of orthopnea or PND means cardiac asthma or food doubt. Patient visited a general practitioner where she was prescribed on inhaler, bronchodilator. Even after taking those inhaler for continued 2 months, patient sinus will not improve significantly because only bronchodilator inhaler was prescribed. And patient was referred to a specialist. Now patient presented to our OPD as follow-up case with persistent complaint of breathlessness and cough. Despite having correct inhalation technique and poor proper adherence, but the inhaler was not correctly prescribed. It is only bronchodilator inhaler. So after taking proper history, patient had complaint of nasal congestion, nasal rhinorrhea. So comorbid condition was not properly evaluated. Allergic conjunctivitis are also present, and history of atopic disease also present in childhood. Patient has also had history of ingestion of second generation oral histamine on occasional basis. So physical examination revealed, of course, the transverse nasal crease, allergic salute, fine, allergic shines. You see allergic rhinitis, especially they usually do like this. You see, either the film stars they do like this during the interview, or allergic rhinitis. Only two type of persons they are doing like this. So the spirometry was done, eosinophilia was done, serum Ig was investigated. The spirometry was suggestive of reversible airway obstruction, suggestive of asthma, and final diagnosis of allergic rhinitis and asthma was made. Patient was advised to avoid dust and cold weather. Inhaled therapy with ICS LABA was started. Combination of montelukast plus levocetirizine was started in the night. Intranasal. Why montelukast levocetirizine in the night? Because levocetirizine has got some sedative effect, and that's why it should be given preferably on night. Intranasal spray was also added. The steam inhalation was given, and patient was followed up to treatment. Patient has improved. So this is the normal. You see horizontal section of the nose, and this is the rhinitis. You seeing a lot of nasal thickening. So allergic rhinitis is an inflammatory disorder of the nasal mucosa induced by allergen exposure triggered Ig-mediated inflammation. And if you see the incidence is about 30% variating in different parts of the world. And most common trigger factors are dust mite, dust and pollen, mold, spats, food and beverages, airborne irritants. And these are the symptoms: sneezing, rhinorrhea, itching eyes, sore throat, ear pain, snoring, and headache, congestion. And if you see the sign, this is called allergic schedule. Most of the time like this, patients are doing like this. So they are not saluting you, but this is the allergic rhinitis salute sign. Transverse nasal crease because they are doing like this. And then of course, allergic chinners, you can see the redness here on this area. So this may be a perennial, seasonal, occupational, maybe factors, so many, but classification of ARIA guideline. ARIA guidelines are the allergic rhinitis and its impact on asthma. They are first time came in 2000, so 22-year-old guideline. Timely they got updated. This allergic rhinitis can be intermittent or persistent depending upon the symptoms. If less than 4 days per week symptom or more than that, this can be both can be intermittent, can be the mild, or persistent can be mild or moderate severe. Both can be as far as the severity is concerned. What management we give? Avoidance of allergen first and foremost. You see, you continue so many medications, but you are not advising the avoidance of allergen. Patient will not improve. Antihistaminic, decongestant for a short period, mostly 1 week. Corticosteroid, nasal spray, leukotriene inhibitors, and leukotriene, of course, antagonist can be given. And of course, the complication of allergic rhinitis or comorbidities. You see, if you see the every third patient of allergic rhinitis is a potential candidate for future asthma development. So you must rule out asthma in a patient of allergic rhinitis. Then chronic otitis media can occur, hearing loss can occur, chronic nasal obstruction can occur, sinusitis can occur. So you have to examine from, and I used to compare, this is my very old concept. I said nose is the first floor, lung is the ground floor. If you have a double story, you see house, then first floor is the nose and ground floor is the lung. So nose is like the first floor of the house, while lung is the ground floor of the house. Whatever will trickle, if you see if your roof is leaking, it is spoiling your floor. Problem not in the floor, it is in the improve. So please treat allergic rhinitis if you want to really have good control on bronchial asthma. So this is the relation of between allergic rhinitis and bronchial asthma. Approximately 80% of the patients suffering from bronchial asthma, they have allergic rhinitis. Means almost every patient. So always ask the symptoms of allergic rhinitis in patient of asthma. Approximately 1/3 of the patient having allergic rhinitis have the risk of developing asthma. So please watch, observe, evaluate on all allergic rhinitis patients for concomitant asthma or future development of asthma. A word about my favorite yoga and asthma beyond the drugs. So we have pharmacological treatment for asthma. We have non-pharmacological treatment of asthma. And this is the Gina slide line. Gina slide. This is not my slide. This says these are the non-pharmacological therapy for asthma, cessation of smoking, physical activity, healthy diet, weight reduction, breathing exercise. Breathing exercise is nothing but yoga pranayama and avoidance of occupational exposure. These are the non-pharmacological strategy for the asthma management as per the GINA recommendation. GINA is an international body called Global Initiative for Asthma Management. And this, he is the Adi Yogi, Shankar. Shankar ji is the Adi Yogi, and Swami Vivekananda, and another, you see, Narayan, it is the childhood name of Swami Vivekananda was Narayan. Narayan are important as far as the yoga practice in the world is concerned. One is the Narayan Swami Vivekananda, another Narayan is Narayan Modi. So this is the yoga day when the United Nations passed. It will be celebrated, and first International Yoga Day was celebrated on 21st June. And then we have done a lot of RCTs and postdoctoral follow, and these are the samasanas and pranayam which we practice here. And one of my students got the postdoctoral fellow and probably first PhD of yoga and asthma in the world. This is our yoga room, where we practice. And these are the benefits. Sure, I will not go into that. You just go through the yoga and asthma, Dr. Surikant. You just type or my student Shruti, you will get 16 publication, index publication, 16 index publication regarding with the yoga and asthma. So this is the evidence-based. These are the 16 publication-based. And in a nutshell, we can say the presence of characteristic symptoms and their presence along with the finding of physical examination sufficient to affect asthma. Asthma is still clinical diagnosis in 2022 also. However, in case you are dilemma, just refer to the expert. Allergic rhinitis is an important risk factor for bronchial asthma. Asthma diagnosis in children is mainly based on recurrent symptoms. Inhaled forms should be considered as compared to systemic formulation, oral formulation. Inhaled medication work fast to improve the symptom and outcomes. Inhaled route is safer also. It can be given during the pregnancy time also, pediatric population also, geriatric population also. ICS containing control and treatment should be initiated immediately as needed. Thank you very much for attention, and sorry for a long lecture and sorry for being late attending this program. Thank you very much. Wonderful, of course, interaction with you. Thank you very much, IMA West and Dr. Ketan Mehta. And the sponsor.
Thank you, Dr. Suryakant sir. You mentioned about Jhansi is known as Jhansi ki Rani for its famous thing. Let me tell you, asthma is famous. You know how it has become because Jhansi ki Rani ke samne UP ke Raja hamare saath the. And that is where you are. The fantastic presentation, a very lucid way you given it. You know, it was like a classical teaching right from students to the postgraduate and postdoctoral teaching, which was there. It had gone thoroughly. So with this, I would request, of course, you continue. We have another star speaker coming up with us, my very near and dear friend, Dr. Parthiv Mehta. The topic for him is, you know, you had made Dr. Suryakant things very easy for him. You already mentioned that now we are talking about beta agonist and whether it is anti-muscarinics and all therapy is gone into inhalation form from the oral form. So now let's talk about the role of oral bronchodilators in obstructive airway disease and what Parthiv has to say, because of course he is now remained with xanthine oxidase inhibitors and what he's going to focus, let us see. So it's Parthiv has already been introduced. I would just say a very humble human being. I have a par excellent clinician. Over to you, Parthiv.
Yes, good afternoon all. And it's my pleasure that I have been given this responsibility to deal with a very important topic while we talk about asthma or COPD or any obstructive lung disease. I sincerely thank especially, of course, both the speakers because they have set in the ground properly. And they've made it a point that for me, the job is quite easier. We could hear Dr. Ketan Mehta talking about the COPD, the cardiology component of it, and a physician's perspective on obstructive airway disease. And none other than Dr. Suryakant, I would have wanted to set in the ball rolling for obstructive airway disease, asthma, allergic rhinitis, and inhalation therapy and bronchodilators, whatnot. I am acknowledging here the sponsors, the German Remedies and Zydus, but along with that, I should not forget the IMA, Mumbai West, and especially Madam Shobha Ahuja and Anushri Mehta, who are already there and they're going to take it further. And you all who have joined on Sunday afternoon, it is going to be lunchtime, so I'm not going to take much of a time to take you away from your delicious lunch, which is going to be a Sunday extra elaborate lunch for most of us. So asthma and COPD, we now know most of the things about asthma. I'm just going to take you through a little more idea about the COPD and asthma comparison. This is the numbers. And India has practically similar number of asthma and COPD, at both the numbers are nearly together. And worldwide, the mortality for asthma and COPD is so huge that if we compare this mortality with other various mortalities, like cardiovascular disease or cancers, respiratory mortality, especially COPD, asthma, and respiratory infection are huge, which is much, much, much larger than the mortality of COVID, which we went across in last 2 years. But still, we were more focused on such mortalities rather than the mortalities which is with COPD and asthma. Good that IMA has taken this initiative to take us through the journey of COPD, asthma, and its management so that we do not reach to the level of mortality. We have gone through all this, so I'm not going to repeat. Only one thing I'm going to tell you here is that in India, about 6% of the children and 2% of adults have asthma. It means that the pediatricians deal with asthma more than the adult or the physicians or pulmonologists. The reason being that in the earlier age, they have more allergic rhinitis, more hyperreactive airways, and as the age progresses, desensitization happens of our airways. Desensitization happens because of our immune system developing, and certain triggers which were remaining very aggressive active in the earlier phase, it would die down so that the airway hyperresponsiveness would go down. Many times it does happen that not only 2% of patients are asthmatic, but a few of those asthmatic would get converted into COPD. They have a non-reversible airway obstruction when, like we saw the case where inhalation steroid was not been given, and a reversible airway obstruction gets converted into an irreversible airway obstruction. So the breathlessness which could have been treated and gone off, which remains persistent, and that persistent inflammation, persistent airway, persistent reduction in the breathing capacity, and the abnormality which are going longer, which is called as COPD, gets developed. It's a pity that when we undertreat asthma, we give patients COPD. And that is to be understood when we are talking about the management of asthma and COPD in Indian context. Why in Indian context? Because in India, we are unique in management. If we follow about the Gold and GINA guidelines, there are always inhalation therapy, which is at the mainstay of the treatment. So when we speak of asthma and COPD, if you see the comparisons, there is an intermittent airway obstruction in asthma versus COPD, which is a persistent, ongoing, worsening, and flow limitation. The cellular inflammation mainly is neutrophilic, and as the sir in previous deliberation talked about the biologicals. Whenever there is a neutrophilic inflammation, there is no role for any biological. There is a role of macrolide, and that is where is the difference in management of asthma, COPD in the higher end we know about. Airway remodeling, when happens in asthma, they get converted into COPD, and in COPD, emphysema develop. That creates a bigger issue of hypoxia, and chronic hypoxics get converted into cor pulmonale, and then that becomes a life-limiting or probably a mortality-leading morbidity. Spirometry, we know, is the key to diagnose. Reversible airway obstruction versus fixed airway obstruction, that is the key. And once I'm doing the spirometry, for sure, I'm knowing now that it is an obstructive airway disease. I am in India, and I am dealing with obstructive airway disease. So I know that for any obstructive airway disease, I need to release the obstruction. So a patient who is presenting in any of these symptoms, whether it is a coughing caused by chronic airway inflammation, whether it is wheezing, whether it is chest tightness, shortness of breath, or ongoing mucus production. A few of them would have been overlapping also, which is called as asthma COPD overlap syndrome. These are very common presenting symptom for all of us. Dr. Ketan also told us about how to differentiate asthma from other diagnostics like cardiac asthma, like other features. When we know that it is hardcore respiratory, hardcore obstructive lung disease, the line of treatment would be to keep the airways open. The patient would come to us, sir, कुछ भी करिए, मेरी सांस तकलीफ कम करिए, सांस बंद तो नहीं हो सकती है, सांस की तकलीफ कम करिए और मुझे breathing में ease out करिए. The one who learns that the fastest, the one who learns how to use the best tool for that given patient fastest is considered to be a great doctor, like the ones we already have heard about. So the idea is to use bronchodilator to open the narrow down airway, to clean the airway which is studded with the mucus, and to reduce the inflammation. So inflammation and mucus would be a different topic, but right now I'm going to talking about only on bronchodilation. And that bronchodilation we know have three major features which we can use. One is beta-2 agonist, which can be inhaled and oral, and the muscarinic agents, and then we have the PDE inhibitors or the theophylline, what we are going to talk about today. Where does it work? The beta-2 agonists are the one which are stimulating beta-2 adrenergic receptors in the bronchi. It leads to smooth muscle relaxation. The anticholinergic agent would reduce the vagus tone, which also ultimately is going to lead to relaxation of the smooth muscles. And the same is going to happen with the PDE4 inhibitors, which is the phosphodiesterase inhibitors, and that is going to be working as the methylxanthines, and that is where the theophylline or doxolin, the topic of day, is going to work on. So the beta-2 agonists have the treatment of the acute asthmatics, which are very quick effective. The muscarinic antagonists would have the lesser useful in asthma, but it is much more useful in COPDs. And methylxanthines, the long-term preventer bronchoconstriction, it has many multifold effects, and that is going to be, we'll be visiting today. So what does happen with this? Whenever we use this, it is helping us to use multiple modalities. So when we are using multiple modalities or multiple medications with multiple different ways, like inhalation therapy, like tablets, like nebulization therapy, there is also a patch available, which is a transdermal patch, which is impregnated with a bronchodilator, which would sustain release, which would give ongoing therapeutic option. This is very useful for the children and elderly who are found to be tired to have taken medications. So ultimately, what does it do? Ultimately, it does is it opens up the airway. It improves the spirometric function. It improves our blowing in and blowing out capacity. So in obstructive airway, the key is to improve this particular function, and that is what we intend to do. Now we know that we have inhalation therapies, we have directly SABA, LAMA, LABA, so many other things. Newer molecules are also coming in. We have breath-actuated devices. But the problem, as we could get through in the previous case when Dr. Suryakant sir was presenting his case, that the inhalation, either the choice of inhaler or the technique of inhaler, which is a bigger issue in India. In India, we know that many of the patients cannot do hand-to-mouth coordination. Many of the patients would not do mouth care. Many of the patients would not have that much of understanding about using inhalers regularly. So inhalation therapy has still, though it is in the guideline, has still not been the mainstay of the treatment. The failure for inhalation therapy has been one of the biggest reasons for failure of control of asthma and of course control of COPD or respiratory symptoms in India, as well as many of the part of the world. So when the critical inhaler errors happen, how does it affect the control? One is the patient characteristic, which is having the effect on frequency of inhaler errors. Low education and high inhaler error frequency has been found to be in the studies or meta-analysis which has been done. The comorbidities, the obesity, the heart disease, cognitive impairment, neuropathies, and lower socio-economical class have been the common reason for us, the pulmonologists, for you, the physicians, even to the family practitioners. कहते हैं उसके साथ सर फोड़ते हैं तो भी वो कर नहीं पाते हैं. The reason is that there is always a limitation for understanding and regular usage of the treatment. Inhaler खाली हो जाएगा तो पता नहीं रहेगा, because there are very few inhalers having markers that now this many doses are being left out. The second association is between the disease outcome and the inhaler errors, that whenever The higher inhaler frequency, error frequency, whenever we find it, the disease outcome is poor. Incorrect inhaler technique also has been found to be with this is poor disease outcome. And quality of life and inhaler error is been directly connected. When I have an error or I am not doing a faulty inhaler technique, my quality of life would not be there. My symptom control would not be there. My repetitive emergency visits would be there. I would require to go to somebody to give me an injection or to give a tablet. So wastage of money, efforts, and frustration, which has been commonly found in using frequently inhalers in certain class of patients. Obviously, somebody like Ketan Bhai or somebody who is practicing in Mumbai like Agam and all, who have the luxury of being in the literate on the who's who class, wherein inhaler would be a very great thing to do. But people like us or Dr. Suryakant sir, as he said, he was in the UP or the most of India, inhalation still is not the mainstay of treatment in bronchodilation. Still the mainstay of treatment remains an oral therapy, and oral therapy is being driven mainly by the theophylline. We do have beta-2 agonist orals like salbutamol, but here we are going to talk about the xanthines, methylxanthines, the theophylline. What does it do? All of us would have seen this famous movie Amar Akbar Anthony, where Vinod Khanna had put on multiple musical instruments and he was playing everything. The same thing does this theophylline in respiratory tract when it has been given as a bronchodilator therapy. It works on eosinophils. It works on T lymphocytes. It also has an effect on mast cells and macrophages. It reduces the recruitment of neutrophils, which is very important as an anti-inflammatory factor in COPDs. We know because there is an eosinophilic, neutrophilic predominance in COPD as a pathogenesis. It works at an airway smooth muscle level to provide bronchodilation, but along with that, it also reduces the leakage in endothelial cells and edema. Most important is the diaphragmatic activity. It improves the respiratory muscle strength, so it reduces the possibility of fatigue. We must have seen COPD patients, and Dr. Suryakant sir has shown us a few phenotypes and pictures, wherein the COPDs you would find that they would be thinning down those pink puffers. Even there would be few blue blotters who would have loaded with fluid, and they would have obesity also, and their diaphragmatic muscles, their thoracic muscles would gradually get fatigued. They would get into CO2 retention later on. Theophylline would reduce that chance of fatigue. It is going to improve the muscle activity also. So it is not simply a bronchodilator, but it also works at a thoracic cage, which is moving the bellow for us to breathe in and breathe out. So within this theophylline group, we have a novophylline, a newer entity, a newer molecule, or rather a newer change in the original molecule group. What is that? Doxolin. It is a methylxanthine derivative with a presence of dioxolin group in position 7. So what we have shown here. The doxolin has both bronchodilator and anti-inflammatory activity because it falls from a methylxanthine group. It has been known to be used in COPDs and bronchial asthmas and pulmonary diseases with spastic bronchial component. It works with the mechanism of action of phosphodilatase inhibition and increasing the level of CAMP. And with that, it is promoting the smooth muscle relaxation. We know it. It has an efficacy similar to theophylline, but when we'll visit that, how it is effective, we would find that it is probably a little better than theophylline in terms of its cardiac safety, in terms of arrhythmogenic activity. Doxolin relatively is a new molecule, but it is having a better safety profile, as it has been mentioned. It does not have drug interaction. Plasma monitoring is not required. That is a very important thing. That is the reason is because it is a unique cardiovascular tolerability profile, and it is highly stable in plasma levels. So it is reducing the chances of cardiac toxicity like arrhythmias, atrial fibrillations. So we don't need to keep on monitoring the drug level. The structure being different than theophylline, it is having its efficacy and action which is little long. So this new generation aminophylline has having an interaction with beta-2 adrenergic receptors also. So not only at the receptor where it should be working as a methylxanthine, but it is also having an efficacy over beta-2 receptors. It is inhibiting the leukocyte diapedesis. So it happens that the anti-inflammatory response is much larger compared to its comparator theophylline. And it is also regulating the leukocyte migration. When it does do this, It reduces the chances of destructive activity which happens in COPD. It reduces the chances of emphysema progression. It reduces the chances of more sputum production. It reduces the chances of more secondary infection and related inflammation, which could be destructive to the COPD patients. It has inability to antagonize calcium-activated potassium channels, so it does not interfere with influx of calcium into the cells. So it is devoid of that, so it is allowing a better action. So it does not increase myocardial oxygen demand. It has lack of arrhythmogenic activity and potential, which has been found in many of the studies, which we are also going to see through. So up to 7 out of 10 COPD patients, we know, Dr. Ketan Mehta told us, that they are at a risk of coronary vascular disease. And how about using a molecule which does not add on to that burden compared to the other therapy, whichever we have been using till now? Very important is to know this for the physicians, consultants who are dealing with patients in ICU. It has been found that it is a rapid and efficient bronchodilator, even in mechanically ventilated patients with acute respiratory failure and airflow obstruction. A COPD or an asthma patient going serious, doxolin, and we have an option of even doxolin injection for such critically ill patients, where there is an improvement in the respiratory airway resistance, so it is decreased. So there is a decrease in intrinsic PEEP. So there would not be much of air trapping. There would be not much of rise in the thoracic airway pressures. So there would be less of airway resistance and improved mechanical ventilation efficacy and the respiratory muscle at a lower pulmonary volume. So it would be providing conditions for the patient-ventilator interaction and for weaning. And that is very important because we know that generally we used to say when we were doing our MD, COPD once on ventilator, always on ventilator, and then vertical discharge. With the newer ventilators and newer modality of treatment, that COPD vertical discharge has genuinely gone down. There is an improvement in the outcome thanks to such molecules which have been made available. What are the clinical evidences for doxolin? Let us visit a few of those. One is this very important LESDA study. That is a long-term clinical trial on the efficacy and safety profile of doxolin in asthma. It was a phase 3 multicenter open label single arm clinical trial wherein the patients were given 400 milligram oral for immediate release formulation and 3 times during the period of the study. And FEV1 within 50 to 80% of the predicted, and those who had showed at least 15% post bronchodilator therapy. So it is an asthma. So the patients were having two endpoints. One was what is the percentage change in FEV1 after 52 weeks, and then secondary endpoints were overall change from baseline, change from the baseline in asthma event rates, and change from baseline in rescue salbutamol usage, the blue pump usage, which is very common. Many of our patients would have it always, and they would say, "Sir, hafte mein to ek khali ho jata hai." It means that we are under treating them. The one who requires more than 2 or 3 or 4 in a week means that severity is much more. In that case, we need to see to it that we optimize, we try to put in the correct medication combinations or correct medication doses and its usage. So if we do that, that would be very easy to manage. And that is what LESDA saw or talked about. Doxolin 400 milligrams significantly increased 2-hour post-dose FEV1 compared to baseline. It means that within 2 hours, it has a great impact. Improvement in the 2-hour post-dose FEV1 remained consistently above the minimal clinically important difference for a longer time during the study period. It means that it is not just giving a waxing waning effect. Once it has started, it persists more than 12 or 15%, which is a very significant outcome. It reduced the rate of asthma events compared to baseline, and it also reduced the requirement of rescue salbutamol. So it has proven its primary and secondary endpoint, except for a very small catch, which was about nausea, headache, dyspepsia, and insomnia. But which would be there with any methylxanthines, which would be there with any new molecules wherein it has been given with multiple other drugs. But it was been found that it was very well adapted by the patients, and it was very well tolerated in terms of its severity. So it has been found in LESDA study that doxolin is very effective and well tolerated when administered chronically. This is very important to be given for long term to the patients with poorly controlled asthma. So these are the patients who had been on inhalation therapy or on other therapy. And when given doxorubicin, their control was been found to better, their quality of life was been found to better. European Respiratory Journal had another publication wherein 227 subjects were enrolled in an open label study, receiving doxorubicin 400 milligram TID for 2 years. Big number, big duration. And what does it talk about? It was showing that doxorubicin significantly improved the change from baseline. It significantly reduced the use of salbutamol, and most commonly reported adverse effect was nausea, headache, insomnia, dyspepsia, but there was no other serious adverse event or death during or shortly after the study. It means that though it has some pinch, but it does not kill, and that is very important, wherein there is no direct relationship of mortality with the drug. It has been taken as a very safe drug to take without any issues. Dorsio 1 and Dorsio 2 studies, these were the breakthrough studies, wherein it compared doxorubicin, theophylline, and 2 doses of doxorubicin and a placebo. This was probably the study wherein it gave us a much more clarity about the usage of dosing in doxorubicin. 483 patients were given, and asthmatic patients with more than 16 years of age with forced expiratory volume FEV1 more than 50 and less than 80, and those who have been diagnosed fully completed as an asthmatic. The lung functions were shown that it increased post 2 hours, and it found to be sustained, and which was parallel at par with the comparator theophylline dose of 250 milligram. 200 milligram of dose was found to be little later or lesser in effect compared to the 400 milligram dose. When it was been given compared with doxo and theo 400 versus 250, the significant difference was not detected between doxorubicin and theophylline in respect to post 2 hours FEV1 from 2 weeks onwards. So though there was first week or probably -7 days when it was been started, doxorubicin was found to having a quick improvement, but theophylline level ultimately went after comparator to after theophylline went to normal along with doxorubicin within 2 to 3 weeks. Both of these reduced asthma events, both of these reduced requirement of salbutamol. It means that both are comparator. And we know that the theophylline have been for long in Indian pharmacopoeia for COPD and asthma. Anybody who visits, anybody who has breathlessness would have taken at least theophylline once in their lifetime in India for sure. So it is not a new entity for us, but the newer entity is doxorubicin, which is improving our confidence on the group, which is improving our confidence because of its tolerability and its safety. So the results of both these studies say that though both of them have compared better, the tolerance and the adverse event rate was lesser in doxorubicin. So it can be proved as better or rather and first choice to use in terms of usage in theophylline group or probably in the group of methylxanthines. Another study where 669 as 696 asthmatic patients were taken, and it was a meta-analysis where 4 randomized controlled trials published in between 2015 and 2018. Ultimately, the results turned out to be the same. The rate of rank of efficacy in terms of the comparator, doxorubicin was first, theophylline was second, and placebo obviously has to be third. And rank of safety, obviously placebo would have been the safest, and then it was doxo and theo. Another study wherein impact of doxorubicin in COPD, another meta-analysis where 120 patients were taken from 20 clinical trials. So it has been extensively studied all throughout all these years. And what it mentions is that in the grade analysis, efficacy was high quality with evidence and safety was moderate quality with evidences for doxorubicin in COPD. It means that if I'm making a choice of doxorubicin as my choice in COPDs or even in asthmatics who are poorly controlled, I would be safe to give this for my patients. My patient would not be affected. Now comes a very important so-called breakthrough, a steroid-sparing effect of doxorubicin. Till now, it has been studied in animal models, wherein authors demonstrated doxorubicin produced a clear steroid-sparing effect in both an allergic and non-allergic model of lung inflammation. Doxorubicin with a low dose of glucocorticoids, dexamethasone, had combined effect, the synergistic effect. Alone, it had no effect. Now, can all of us ask ourselves, have we not done this in our day-to-day practice? for sure, any severe asthmatic or any persistent COPD patients, moderately severe patients, would have taken dexamethasone or any of the low-dose corticoid along with a theophylline group, or maybe now doxolin in their lifetime. And that is what I put in here. This we have been doing day in and out in our Indian practice. Though it has come to an animal model, it will come to use formally in the Western world. But we have huge experience of doing this in our day-to-day practice. Why cannot we put it in a formal study or in a formal, sort of an observational study or a randomized control trial, which would help us to generate an evidence which would be probably the largest. The world's largest body, IMA, if takes up this kind of a survey or this kind of a study, it would be a great service to the mankind. We would be able to enhance the confidence amongst the Western world because they have been throwing away methylxanthine a lot. We have already it in our pharmacopoeia, which probably has not found its place in the guidelines. The reason may be so-called safety issues or so-called tolerability issues or whatever it can be. I would ask Dr. Suryakant sir or Dr. Ketan Mehta or anybody else who can contribute. Why are we not able to bring them in our routine guidelines for routine usage, where it is there in armamentarium or pharmacopoeia of every clinician in this country? May it be a registered medical MBBS clinician, allopathic or non-allopathic also. So let us recap now about doxolin. First of all, why it has come in? Because inhalation therapy in India has been really struggling. Often inhalation formulations are associated with poor adherence and inadequate responses. And the use of safe, effective, inexpensive oral option has always been encouraged in such patients by the clinicians or even demanded by the patients. So when we talk of methylxanthine and doxolin, it is not just another theophylline, but it offers better safety and pharmacokinetic profile. It is a cardio-safe, and its efficacy and safety, it has been proven by the studies what we have placed here. So having known that, how about taking it further, that when we use methylxanthine in our armamentarium, we would choose probably doxolin as the first choice because it has a steroid-sparing effect also, because it has an anti-inflammatory effect also, because it has a sustained bronchodilation also, because it also provides certain virtues and benefits which a typical methylxanthine would have, like diaphragmatic muscle or respiratory muscle enhancement of the activity and whatnot. I sincerely thank and acknowledge my team here because they have given me an opportunity to be with you all on this Sunday afternoon, having not taken my daily rounds, and they have been the one who are working. And once again, I sincerely thank you all for a patient hearing and allowing me to come to you all through this webinar. Thank you again.
Thank you, Parthiv. It was such a fantastic presentation. Now, of course, we will take up with questions. We have obviously overshoot. Everyone has taken a little more time. Probably it really realized this should have been a single session, be it with either Parthiv or be it with Dr. Suryakant. That full session could have been only on that. So nevertheless, let's take quickly few questions. Question coming from Dr. Hemant Joshi, Pune, is, are there any adverse effects of bronchodilators on kidneys? So let me take up that questions. Luckily, there is no major adverse effects of any bronchodilators kidneys, and that is how pulmonologists are not so close to nephrologists per se. They are close to cardiologists, yes, definitely. So that is one good thing we can say over here. Another interesting question is, if IG is raised before the treatment, and then if the patient gets relief, do we have to repeat IG test? This has been asked by Dr. Ajay Kenny, Mumbai. I will ask Dr. Suryakant. I think I can't see Dr. Suryakant here. Dr. Suryakant is Dr. Suryakant. Priyam, can you check it? Is he there? Or I can, even Dr. Parthiv can take that question. Do you recommend to go for?
She's logged out, sir. I think I will check his connectivity.
Yeah. So
Yes.
let's.
Okay. Let us talk about IgE.
Yeah, Dr. Suryakant has joined. Yeah, you can take Parthiv. You can continue.
No, Suryakant sir, let him. It's his forte. So is.
Sir is coming in 2 minutes. Actually, there's some issue in the web connection.
Okay, no issue. So till then, I think this question, Parthiv, you can take meanwhile.
Okay. IgE, we know IgE is associated with the presence of allergy as a component, or rather hyperreactivity as a component. It does not necessarily has to correlate with the clinical severity or the severity of the symptoms. So if a person is asymptomatic, we do not change the number of IgE. Many times the reverse is also true. Patient might have a very severe allergic symptoms and IgE still would persist to remain lower normal. Like that was a case where Dr. Suryakant sir showed that 350 was IgE. So it does not directly get reflected. So simply chasing IgE is not the right approach on treating any allergic component, whether it is a skin allergy, whether it is allergic rhinitis or asthma. But yes, in case if at all we have started treating and the patient starts getting a rise in the IgE, that is the time we have to aggressively act on it. Either we can use a blanket therapy like glucocorticoids, or we can go for biologicals, or such are the patients wherein in Indian context we talk about allergic bronchopulmonary aspergillosis or colonization of aspergillus or chronic worm infestations, which are the features very commonly been associated with rise in IgE. So in case if we can use those modalities to treat, it will be easier to control that IgE level.
Okay. There is another surprise question which has come from Dr. Prasenjit Dhawle from Mumbai. Please guide us about role of magnesium sulfate in the treatment of obstructive airway disease. So I think Parthiv, you can take this.
First you take, because it's a combined role, because you have used magnesium sulfate in arrhythmias a lot.
Yeah. So we have a role of MaxSulf in refractory ventricular arrhythmias. In fact, we have heard this molecule right from when we had done posted for gynec obstetric practice. That time we have heard this MaxSulf. Obstetrician have used it in preeclampsia, eclampsia. Then it came to the role in refractory ventricular arrhythmias in coronary events. And now there has been role which has been stipulated. So let's hear from Parthiv about that. So let me tell again, from a family physician point of view, cardiac, yes, no OPD role for MaxSulf. That is definitely. Now, Parthiv.
Yes, MaxSulf has a typical effect of calcium channel blockade, and because of that, it would relax the smooth muscles, simply like that.
This meeting is being recorded.
So when I am using magnesium sulfate, it is probably one of the last resorts where I'm having a refractory asthma. When I have fired with steroids, I have put in loaded with inhalation like nebulization. I have done all my therapies. I have given IV aminophylline, or I have given IV doxolin. I have given all possible therapy, and still I am finding that it is a refractory asthma. I can safely use magnesium sulfate, because magnesium sulfate otherwise has been so safe to be used during pregnancy or during postpartum phase, and cardiologists have been using it left, right, and center. So that would be easy to be used even in such a refractory asthma, though it is a very limited use because of availability of better molecules and better bronchodilation therapies. So, but still, yes, it can be used hypothetically.
Okay. There is a question here. Dr. Suryakant has come. I was just wondering, UP ke Raja kahan chale gaye? So the question from Dr. Amanda Pereira from Mumbai is, in a patient of bronchial asthma or allergic rhinitis with frequent exacerbation, when should we suspect ABPA?
Yeah, great. So I think around 4 to 5% of patients of asthma, they may manifest as severe asthma, and some of them, they manifest as a very important complication that is called allergic bronchopulmonary aspergillosis, ABPA. So if your patient who was responding very well on whatever the treatment you have prescribed, now the difficult symptoms are there, you have increased the dose of inhaled corticosteroid, you have gone through the higher dose of the rather high dose of ICS as in step 5, and you have given also add-on therapy, probably tiotropium or so, and is still patient not responding, rather deteriorating. So in routine investigation, you advise serum IgE, eosinophil, and pulmonary functions, and you find that serum IgE is raised. So if eosinophils are raised, serum IgE is raised more than 1,000, this is the point of suspicion for ABPA. And then, of course, you will do ABPA panel testing. ABPA panel testing means Aspergillus specific IgE and Aspergillus specific IgG. And also, same time, you will do a radiological investigation in the form of HR, CT, thorax. And if you find concomitantly the central bronchiectasis, then of course it again goes in favor of ABPA. So that is treatment. If more, the serum IgE is more than 1,000, your patient of asthma background is not responding to your treatment, rather you have maximized the treatment, you have ruled out the all comorbid condition, you have treated all the associated comorbid condition fully and maximized the treatment. And then, of course, serum IgE, total serum IgE is raised. And finally, serum Aspergillus specific IgE and IgG are raised. Sometimes you can take the help of skin prick test for the Aspergillus. And all these are, if raised along with these central bronchiectasis or any CT pattern of ABPA, then, of course, this is the final diagnosis of ABPA. And, of course, you can treat with oral corticosteroid alone or in combination with antifungal. Yes, Dr. Mehta, probably your connection has lost.
I think his
It seems
connection
Dr.
is-
Mehta has lost the connection.
Yeah, probably it appears.
I think, Parthiv sir, there are certain questions we have questioned in chat box also.
Yeah.
If you could take up one or two.
I'll read it out. Yeah, one of them is, sir, the difference between derifylin, doxolin, and acebrophylline. I think derifylin and doxolin we have already taken. Acebrophylline has been derived out of a notion of combining both together, a bronchodilator with mucolytic, which would have a very specific effect in COPDs, wherein mucus plugging is one of the biggest issue for airway improvement of the airflow. So that is where it has been found to be effective, and it has been one of those which has been extensively used of late in Indian clinical practice also. Larger studies are yet to come, but yes, it has been for the usage which has been used at the moment. It has been found to be effective.
And Dr. Parthiv, one question in the chat. I don't know whether this has been addressed or not. This question is from Dr. Anu Nigam Jhansi, which is we were discussing the Jhansi, which is the best drug for the allergic rhinitis along with montelukast. I think he's talking of combination of montelukast with so many combinations are available: fexofenadine, blastine, the levocetazine. You see, the combination all are the same. A little bit difference in efficacy and the safety profile, because if your patient is not an executive class, means he can afford the sleep in daytime also, so better you go with the allergic with montelukast and levocetazine, because this drug, if somebody is executive class, somebody is teacher, medical student or professor category or any executive class, even politician, because in daytime they have to deliver bhashan. So I think you should avoid the levocetazine combination in such type of cases, and you can go for the blastine or fexofenadine because they are the non-sedative ones. So that is how you can select. And the question is how long? If till you are comfortable and patient is comfortable, you can use. I personally have used up to 5 years, 7 years, or even more than that. But you can explore now the add-on therapy and alternative therapy also, because it has been seen, it has been practiced also. Now evidence is also that the nasal wash is also a very important non-pharmacological intervention where you can get good results for allergic rhinitis. In Uttar Pradesh, we call it as, or in terms of yoga, we call it Jal Neti. I don't know which vernacular language you use in Marathi for this. But this is in our area, it is called Jal Neti. So nasal wash or nasal douche, usually most of the NT people, they are using nasal douche. So I think this can also be practiced, Dr. Anurigam. So it is your choice, which combination you want.
Thank you.
Yeah,
Sorry, sorry, it was just disconnected.
We were just asking the question in the chat box, and we were giving answer spontaneously. So we were a speaker also and moderator also.
Probably
we took over your role also.
That's good. So I think we have covered most of the questions. We're getting, of course, now the time is also shooting in the lunch time. So before I hand over to Dr. Anushri, let me my special thanks to both our esteemed guest faculty, Dr. Suryakant and Dr. Parthiv, who have been really good enough and to spare their valuable time in spite of their busy schedules and come for this webinar and highlighting us on the very interesting subject on crosstalk between allergic rhinitis and obstructive airway disease. So thank you, both of you. I would hand over to Dr. Anushri, our IMA Mumbai West CGP Secretary, to propose the vote of thanks. And of course, do join for e-lunch kept at your respective places. So do join, don't forget to that.
Great.
So hand over to you, Dr. Anushri.
Thank you, Ketan. Thank you, Parthiv, for joining us. And thank you, Jadis. Thank you very much for sponsoring the event.
Anushri.
Thank you, Professor Dr. Ketan. No learning is complete without expressing gratitude to our gurus and everybody who made it possible for us to learn. With this thought in mind, I would like to thank our gurus of the day, Dr. Suryakant, Dr. Ketan Mehta, and Dr. Parthiv Mehta, for a very comprehensive teaching of a very complicated topic. I would also like to thank our education partners, Zydus and German Remedies. They have also provided us the platform for the webinar today. I would like to thank Professor Dr. Ketan Mehta, our IMA Mumbai West President, for arranging this webinar, and our organizing secretary, Dr. Shobha Ahuja, who's always been a pillar of support for IMA Mumbai West. Last but not the least, I would like to thank our audience, whose presence is a constant source of inspiration for IMA Mumbai West to continue our educational endeavors. I would like to announce the program Physical CME that we have on 13th October at the IMA Mumbai West branch. We have a very interesting program. We have a CME followed by a cultural karaoke program for 1 hour. The topics for the CME on 13th are expanding the armamentarium beyond metformin, quest to put peptide in a pill, the journey of oral semaglutide by Dr. Sundar Krishnan, not all blood cancers require treatment by Dr. Shilpa Gupta, and highlights of ESC 2022 Barcelona by Dr. Ramesh Dargad. We also have the vaccination drive, which will begin from 13th between 2 to 4 at the IMA Mumbai West branch. Thank you. Thank you. Good afternoon to all.
Namaste. Bye.
Thank you.
Thank you, all of you. Thank you, sir. Thank you.
Thank you so much. Thank you.
Thank you so much, sir. Thank you. Thank you, Parthiv sir.
Thank you, sir.
Thank you, Ketan sir. Thank you, Suryakant sir. Thank you, Dr. Anushri, for your